In 1 minute, we will start the introduction and lecture. Thanks to all the audience who follows our broadcast. We have the honor today of having Dr. Javier Saavedra. He is a professor of neurosurgery at Universidad del Rosario, completed a fellowship in endoscopic skull-base surgery, is the scientific director at CIEN, and director of the Neuroanatomy and Hydrocephalus Laboratories. Today, Dr. Saavedra will share his lecture, Transorbital Neuroendoscopic Surgery, in the Avant-Garde of Endoscopic Skull-Base Surgery. Please type write your questions in the Q&A panel. We will read them at the end of Dr. Saavedra's intervention. Welcome, Dr. Saavedra, and thank you. The microphone is yours.
Thank you, Pablo, for having me here. So we're going to talk today about transorbital neuroendoscopic surgery. So let me see. So what is it? TONES. Well, TONES is not a single approach, but it's a group of surgical corridors that reach or pass through the orbit, aiming to treat pathologies that are within, adjacent, or even at a distant anatomical regions by using the orbit as a corridor. So it's just as much as the endoscopic skull-base surgery, endoscopic endonasal surgery, which is, are not just a single approach. You have purely a transsphenoidal approach, but you also have a transcribiform approach, you have a transplanum approach, you have lateral extended approaches. So TONES is the same. It's a group of surgical corridors. So 10 years ago, Dr. Chris Moe published this important paper. She summarized for the first time a series of patients treated by this technique. So she published this series of 20 patients, and she summarized the anatomy, and she quickly, I'm sorry about this. It's Siri that's talking here. So, I'm sorry. Let's give a minute. Do you know how to stop Siri, Pablo? Let's give a minute. Listo.
We have difficulties here. We'll restart.
I'm sorry, I'm here.
Okay. Go ahead, doctor.
Yeah, I'm back. So Dr. Moe realized of the advantages of this technique. So she saw that the trajectory, the angle of vision was more favorable. It was almost parallel to the main axis of the orbit, and the trajectory was shorter and more direct to treat lesions that are all around adjacent to the medium skull base. So she depicts in this picture the different approaches to the skull base. Those are open approaches. This is the transnasal endoscopic approaches, and this is TONES. So TONES has the advantage of having a wide range of visual field for treating lesions that are very anterior and also very posterior. So 10 years ago, when Dr. Mo published her paper, there were no more than 3 published articles on the subject. And very progressively, throughout the years, the number of papers has been rising, but nevertheless, the studies are still, you'll see anatomical studies are almost the same number that in vivo surgical studies. So that means that the anatomy is not totally developed on this technique. This is a systematic literature review published this year by Dr. Burol and his group, and he found 42 studies included in this systematic review. And all these studies even included more than 500 patients. So let's check on the anatomy of this technique. So I'm pretty sure most of you are familiarized with this article. Dr. Rutten and Dr. Carolina Martins published this paper some years ago, the rule of 7. So we all have in our mind this picture of Dr. Rutten telling us that the orbit is a pyramid. So it has 4 faces, very well delimited, and it has 7 bones, 7 muscles, 7 nerves. So that's the idea that most of us have in our mind of what's the orbit. Most of us neurosurgeons are not really familiarized with the anatomy of the orbit. So out of these 7 bones, we're going to talk about 5 bones. So this is the frontal bone, this is the radar wing of the sphenoid bone, this is the zygomatic bone, this is the maxillary bone, and this is the ethmoid. And we have 2 major anatomical landmarks. This is the optic canal, this is the superior orbital fissure, and this is the inferior orbital fissure. And those are the most important landmarks that we'll have to know to talk about tones. This is the optic nerve. This is the ophthalmic artery. This is the ophthalmic nerve with its branches. So this is the lacrimal nerve, the frontal nerve, the zygomatic nerve, and the infraorbital nerve. So what's important about this anatomy for the tones approaches, it's that we have to imagine that just behind this bone anatomy, you have access to the neurocranium and also to extracranial compartments. So as you can see here, you have access to the anterior fossa and to the medium fossa. So the most important landmarks here, we're going to see that more on that, are when you drill the bone, you will have access to the dura of the anterior fossa, the dura of the medium fossa, and this structure, which are going to be very useful, is the meningo-orbital band, which is an area where the dura becomes into the periorbital. This is the optic nerve. So we have to imagine that just behind these bony structures, you have the brain and all the neurovascular structures. If you have this view, this medial view, you can have access even to very medial structures as the anterior clinoidal process. And if you have a look laterally, then you will have access to the temporal lobe, and more laterally, and even the temporal pole. So we will see, this is a projection of all the compartments that you can access through the orbit. We have the anatomical landmarks that we just talked about. And if you drill through these bones, you will have access to different compartments. Let's see. So this is a picture of Dr. Mo's paper. She tried to summarize the anatomy of the orbit in these 4 quadrants. And this is, of course, useful in an anatomical point of view. but it's not really very useful in a surgical point of view, because the bony anatomy is not really like that. So you have different papers trying to summarize in a different way how the orbit can be accessed. And so you have different types of quadrants. But as I said before, this is not really useful from the surgical point of view. She summarized also the different corridors that we used for axis in the orbit. So she developed what we call now the 4 pillars of tones. So the 4 pillars are 4 types of corridors for axis in the orbit through these 4 quadrants that she summarized. So the first one is the precurruncular approach, which aims to access the more medial structures in the orbit. So you have to do an incision, a transconjunctival incision, which is not difficult to do, but has more morbidity than accessing through an incision that is outside the conjunctiva. This is the superior eyelid approach, which is done by doing an incision in the superior eyelid, of course, and it's not getting in contact with the conjunctiva. This is the lateral retrocanthal approach, which of course aims to go to the more lateral part of the orbit, and has also the risk of carrying morbidities for the more frequent presence of scarring and the need to cut the lateral canthus. And this is the preseptal approach, which aims to access the orbital floor and the most inferior part of the orbital content. So of course, this also needs to be done through an incision in the conjunctiva and all the morbidities carried by this type of incision. So very progressively, the surgeons started to realize that you really didn't need to do all these kind of incisions, because when you do a superior eyelid incision, you could access most of the orbit. So this is a cadaveric dissection that we performed in our laboratory. This is the usual incision that we used. You do it through a superior eyelid crease, and then you stand the incision just a little bit lateral. And you can see here how wide exposure you have. So you have a very wide exposure on the orbital roof, on the lateral portion of the orbit, and also on the orbital floor. So as I was saying, surgeons around the world started to realize that. So in this study made by Dr. Lee, Dr. Prevadello, and Dr. Carao, they was trying to compare how easy it was to accessing the inferior and medial third of the orbit. And they realized that just this part is easier to access through an endonasal endoscopic approach. But all the other 2/3 of the orbit are more easily accessed by a superior eyelid approach. So how is it done? So you need to realize that you have a picture of the orbit in your mind as a pyramid with evident corners. And really in surgery, that's not what you have. In surgery, you feel more like you are working on a cone. So you don't have obvious corners, and you can get lost very easily. So you need to quickly identify anatomical landmarks. And also, I need to say that neuronavigation is very useful. So once you start drilling the bony structures, the orbital walls, then you will get access to the anterior fossa dura and the middle fossa dura. And then you will get a better sense of orientation. Then after you have opened the dura mater, and if you have a big tumor or a tumor extending very posteriorly, then you will be finding very useful the neuronavigation. So let's start having a clue of what are the most important landmarks for doing the transorbital approach. So the most important landmarks are the superior orbital fissure, are the optic canal. You will find the optic nerve very, if you keep dissecting posteriorly, you can injure the nerve if you are unaware of its presence. You will find this structure that we talked about it before, the meningo-orbital band, which is separating the anterior fossa and the middle fossa. And you will find the infraorbital nerve and the zygomatic arteries and nerves, which are its trajectory is lateral and inferior. So let's perform a superior eyelid approach. So you will do an incision just over a crease on the superior eyelid, and then extend this incision just 1 centimeter lateral. Then you'll find the periorbicularis muscle. You will dissect it, as you can see here. You will go over the superior tarsum, and you will get to touch the orbital rim. So you have to dissect until you touch the rim, and you will get to get in contact with the periosteum of the orbital rim. Then you will start a subperiosteal dissection, and then you have different options depending on where the lesion that you want to operate is located. So let's start doing the dissection laterally, which is the more classical point of view. So you will have this view. You will have the superior orbital fissure here. You will have the optic nerve and optic canal, and you will have the inferior orbital fissure here. And this area between those fissures, it's the greater wing of the sphenoid bone, and just behind this bone, you will find access to the middle cerebral fossa. So this is the first anatomical landmark you will need to find. Then this is what you'll see. This is the dura mater of the anterior fossa, the dura mater of the middle fossa, the meningo-orbital band, the periorbita, and the optic nerve. And then if we drill more laterally, which is a very important part of this approach, you will get access to the temporal fossa. So it's very useful to drill the lateral wall of the orbit here, and you will find that it's not really temporal bone, but temporal fascia. And you will find that very useful because that's going to give you more room for your tools. So it's more easy to handle your tools, your surgical tools, if you drill the lateral wall of the orbit. Then if you keep staying extradural, you will find these structures. You will find the trigeminal nerve branches. You will have the maxillary nerve exiting through the foramen rotundum. And this is superior orbital fissure. This is the ophthalmic nerve, and this is the greater wing sphenoid. And if you keep accepting behind, if you just stay extradural or you get interdural, so you will get access to the other branches of the trigeminal nerve. So you can see here the ophthalmic nerve, the abducent nerve, and you will have access to the lateral wall of the cavernous sinus. And even if you go behind that, you will get access to the foraminal valley and the exit of the mandibular nerve. You can also see here the middle meningeal artery. And if you keep dissecting behind, more posteriorly, you will get access to the Gasserian ganglion here. Here you can see very, very well exposed the Gasserian ganglion. And also, if you get more medial, of course, you will get access to the clinoidal internal carotid artery. And you can, of course, you can open the dura and you will get access to the intracranial compartment. Then you can see the frontal lobe, the temporal lobe, the MCA, and you can just keep dissecting the sylvian fissure for having a better exposition of your brain vessels. Then this is what we have right now. We have exposed laterally, and now we want to expose superiorly. So this is what we're going to find. Oh, I'm sorry, this thing again. Yeah. So superiorly, we will have access to these structures. This is the anterior cerebral fossa, dura, and this is the ethmoid, and this is a structure that's called the orbital beak. This is the point where the orbital roof starts becoming convex. It's called the orbital beak, and through this orbital beak, you will find the ethmoidal foramina, the anterior ethmoidal foramina, and if you keep dissecting the posterior way, you will find all the rest of the foramina more medially. And if you keep dissecting medially, you will find the optic nerve here and the anterior clinoid process dura mater here. This is the meningo-orbital band. And then this is the optic strut just between the optic nerve and the superior orbital fissure. So it's a complex anatomy. I think even if you're doing the dissection, if you're trying to learn this anatomy from an open approach, or from an endonasal endoscopic approach, and this is a different point of view, so you have to get used to this anatomy. So finally, we get into the more superior and medial portion of the orbit, and you will get to see these arteries, the posterior ethmoidal artery, the anterior ethmoidal artery, and this is a very important landmark because once you have identified the posterior ethmoidal foramen, you are really near from the optic nerve. You're really near from the optic canal. So it's not more than 7 millimeters of distance between the posterior ethmoidal foramen and the optic canal. So if you start dissecting superiorly and you get access to see the anterior ethmoidal foramina and the posterior ethmoidal artery, you will very quickly know that you are very near from the optic nerve, and you have to be aware of it for it doesn't injure the nerve. Okay, now let's go lateral. So once that we have dissected medial and superior and lateral, we're going to have to go even more lateral. So this is a zygomatic nerve. And if you go through it, if you drill through it, you will get access to the temporal fossa. As we just said, that's one of the important steps during the surgery, because drilling this bone structure will allow you to handle more easily your tools during the surgery. Then if you want to keep going more inferiorly, you will find this nerve. This is a zygomatic nerve and its branches, which are the zygomaticofacial and zygomaticotemporal nerves. And you will find this structure, which is the inferior fissure, the inferior orbital fissure. So the inferior orbital fissure is a very important landmark because medial and inferior to it, we will find the maxillary sinus that we can see here. All this pink area will be the maxillary sinus. But if you go lateral, you will have access to two different compartments, and which the structure that is separating these two compartments is this nerve, this artery, this vein. That's the infraorbital nerve. That's the infraorbital nerve. So the infraorbital nerves, which runs perpendicular to the infraorbital fissure, is going to separate the fissure into an anterolateral fissure and a posteromedial fissure. And we will see what happens if we drill in every one of these compartments. So if we drill in the anterolateral compartment, we will get access to the infratemporal fossa. This is the infratemporal fossa. But if you get to drill in the posterior medial compartment, you will get access to the pterygopalatine fossa and its contents. So you will get access to the lateral pterygoid muscle and all the content of the pterygopalatine fossa. So again, this is the anatomic view of the infraorbital fissure, and this structure that's perpendicular to it is the infraorbital nerve. So anterior to it is the infratemporal fossa, and posterior to it is the pterygopalatine fossa. So here we have the superior orbital fissure, the radial wing of the sphenoid, the zygomatic bone, and as you can see here, you have drilled the radial wing of the sphenoid. You can see the middle cerebral fossa dura, and just below you can see that if you drill this bone, you will have access to the pterygopalatine fossa, and this is the lateral pterygoid muscle. If you keep dissecting posteriorly and you dissect the lateral pterygoid muscle off the way, you will have access to the foraminal valley and the mandibular nerve. And if you keep your dissection extradurally, just above the rear wing of the sphenoid, you have this view. And you can dissect, you can drill the bone, and you can have access to all the trajectory of the mandibular nerve. This is the tube, the Eustachian tube. If you cut the tube, you will have access to the intrapetrosal carotid artery. You can see here, this is the horizontal portion of the intrapetrosal carotid artery, and this is the vertical portion of the carotid artery. So you're very near for very dangerous structures, but you can actually see it in surgery. So this is the picture that we have made in our laboratory. This is a picture depicting the different corridors to the different compartments that you can have through the orbit. Well, this is just an anatomical remark, an anatomical tip. For doing the dissection inferiorly, you have to cut these nerves, the zygomatico-facial and zygomatico-temporal nerves, which are branches of the maxillary nerve. There's no really big adverse effects of cutting these nerves because they have connecting branches with other branches of V2. Okay, so let's have a vision into an actual surgery of thumbs. So we position patient in a neutral position of the head, just a little rotation, contralateral of the lesion. And as I said, we operate over patients with navigation. We also use ultrasonic aspiration and neuromonitoring. And we have this setting of the operating room. We have the scope screen just in front of the surgeon. We have the screen of the navigation on the side. We operate with a multidisciplinary team composed mainly of oculoplastic surgeon. You know, it's as we the neurosurgeons are familiarized with the orbit surgery, ophthalmologists are not familiarized either. So you usually have to find an oculoplastic surgeon that's used to these types of approaches. And also, you can do the surgery with one assistant or two assistants. It means 4 hands or 6 hands. If you have a second assistant, it's very useful for you. He's going to handle the brain retractor, and that's going to be very useful. We kind of use dynamic retraction because we release the retraction every 10 minutes just to allow for the content of the orbit to release the pressure. So every 10 minutes we release the brain retraction. So techniques that we use are the same techniques that you use during an endoscopic and nasal surgery or during a microsurgical approach. So let's see this case. This is a female patient, 47 years. She had a history of 2 months of amaurosis and hypoesthesia, and she comes with this lesion. You can see a very hyperstatic bone, and this lesion just lateral to the cavernous sinus, very well vascularized. There was this image we thought it was an aneurysm, but turns out to be just a calcification. So let's see what we have done. So we start with the superior eyelid dissection. This is a periorbicular muscle, just above the canthus, the tarsus. You get access to the orbital rim, and you dissect the periosteum. Then you have exposed the orbital rim superiorly, laterally, and inferiorly, if that's what you need. You start with a subperiosteal dissection. So you want to keep the periorbita undamaged, because if not, the periorbital fat is going to be on your way on the surgical field. This is the zygomatic temporal nerve that you coagulate and cut. Then you have access to the most inferior part of the orbit. Then you start drilling the orbital walls. So you're drilling the superior wall, you're drilling the zygomatic bone, you're drilling the sphenoid bone. Just keep in mind this patient has a very thick bone, he has plaque meningioma. So drilling is more hard than usual. Then you have, as you do in the nasal procedures, you want to have a wide dura maris position. This is the meningo-orbital band. We have to drill a little more. We are drilling the inferior orbit, having access to the infratemporal fossa. More bone to drill. And then we start opening the dura mater. Again, the same way you do it with an endonasal approach. So you want to keep extra capsular. Here we have for dissecting the dura from tumor capsule. It's really attached because the tumor is compromising the external and internal layer of the dura. So we have to start dissecting the tumor from the brain parenchyma. Here still trying to go extracapsular. And then we find a plane. We proceed as usual with any tumor. Perform the dissection of the tumor out of the brain parenchyma. We cut all these compromised dura. Just medial to it is the cavernous sinus. We keep dissecting the tumor from the brain, and as you can see, there's no brain retraction. All the retraction we are doing is on the tumor. We proceed as usual. We perform a debulking of the tumor. We're making easier the dissection. Keep dissecting the tumor progressively. It's really attached with this neovascularization. keep taking out of the tumor. You can bulk in the tumor progressively. And we can finally see most medial part of the MCA. You will see it right away. Here we are. We use the same tools, same surgical tools that in endoscopic skull-based surgery. And finally, we perform hemostasis with any product you like, surgical, Focil. And you proceed with the closure. We use a patch, use glue, and we reposition content of the periorbital. So this is the tumor we just saw. This is the pre-op and the post-op CT scan. It's a different case. Also, this is a tumor getting down into the pericardial fossa and infratemporal fossa. This is the post-op. You can see how you can access very, very inferiorly, actually, into the infratemporal fossa. And this is the cosmetic results. This is the early follow-up. You can see scar is very, very superficial, very hidden. And you have all kinds of pathologies that you can treat for this approach, all kinds of tumors, CSF leak, all kinds of tumors into the orbit or adjacent to the orbit. So what are the limits? What are the anatomical limits of this approach? So we still don't know. There's a Laterally from South Korea who performed this study comparing scopic endonasal versus transorbital surgery. This is the biggest, the largest series of cases performed by him. It's more than 40 patients. And as you can see here, he has all kinds of tumors in all kinds of localizations. You can see how far posteriorly and inferiorly into the posterior fossa he can get. It's impressive. It's really impressive. So you can also perform combined approaches. So you can use an endoscopic endonasal approach and tones. So you can also use a tones and an open approach. As we saw in the surgical video, we can access the sylvian fissure, and we can dissect the sylvian fissure. In this paper, Laterally is performing a cadaveric dissection, and he is going transentorial. So in transentorial, and you can see here, he's accessing the posterior fossa. You can see the brain stem. You can see the anterior choroidal artery. It's really impressive. And more recently, you have this paper, which I found very interesting. This big tumor with this big cyst, the posterior fossa, it was accessed through a tones. As you can see, a tones more direct and a more shorter way to get into this tumor. You will usually use an open approach, an extensive open approach or maybe more than one single approach for accessing this tumor, for addressing this tumor. And you can see the post-op results. And he found, he uses this very beautiful technique. So they had this idea. They used a port, an endoscope port. This was 3D printed, and they put their scope to this port, and the port was lateral to the orbital rim, you see? So he was having a wider angle of vision with this port, which was lateral to the orbital rim. So you can also have, during surgery, you can just cut the orbital rim for having a better mobilization of your scope, but you usually want to keep the orbital rim. So these guys use this technique, which I found very interesting, and we tried it. So we said, well, let's do it. So we went to our internal anatomic lab, and we did it. So we found it was really, really useful. So we performed the usual approach with the subperiosteal dissection. We drilled the lateral orbital wall, and then we just dissect temporal muscle, and we put the scope to it. And you can see how beautiful view, a beautiful angle of vision we have by putting the scope to this little hole there. Of course, there's complications. Interestingly, the complications are not severe. Most frequent complications are ptosis or proptosis, diplopia, which are most of the cases transient, and CSF leaks are very, very infrequent. Just 4% of presence of CSF leak because the content of the periorbita, it's a very well tissue, it's a very good tissue to seal the defect that you perform when you're doing the approach. So in conclusion, tones provide advantages reaching different pathologies and target areas through the skull base. First, it allows the surgeon to avoid extra soft tissue dissection. It provides a relatively short and direct corridor. Tones is not going to replace the transnasal or open approaches, but I think Tones has established as a useful and important tool, either single or combined, that should be in the armamentarium of a skull base surgery team. Thank you very much.
Well, thank you for your lecture, Dr. Saavedra. I am sure all the audience has learned from your robust experience. Now we're going to ask some questions given by your audience. So Dr. Madriñan is asking, are there any bone landmarks or relationships to the interdoual internal carotid artery through the approach?
Yes, the most important landmark is the meningo-orbital band. So you know, you can quickly access the superior orbital fissure, and then you can find the optic canal, and you know, between them you will find the optic strut, and just laterally from the superior orbital fissure you will find meningo-orbital band. So that's the most important landmark for accessing for doing the interdoual dissection.
Okay, thank you. The next one is related to brainstem lesions. So what is the role of tones in the treatment of brainstem lesions?
Well, I haven't seen and I haven't read any paper on that. As you could see on the images, you have a wide access to the lateral face of the brainstem, and as you could see in the last paper I showed, you can go transtentorial, but I haven't read any paper on that. I think it's possible.
Okay, thank you. Here we've got a question in relation to the trigeminal nerve. So in your experience, as you can access the trigeminal nerve, is this technique a viable approach for atypic trigeminal neuralgia?
I haven't read any paper on that too. But well, if you want to perform an ablative procedure, I'm pretty sure that it is. But I think there's percutaneous procedures that are more easily done. And if you want to do microvascular decompression, I don't think that's the right way to do it.
Okay, perfect. Dr. Torres is asking, under which circumstances would you consider a combined tones plus an open transcranial approach?
Yeah, that depends on the extension of tumor. As we saw in the one of the papers, that has been done. More frequently, transnasal approaches, because the tone approach will give you access to the lateral portion of the median skull base, and also you have access to very lateral portion of the temporal lobe. But if it's really, really lateral, then you won't get to put the scope in this direction. So in that moment, you will have to perform an open approach, maybe a minimally invasive open approach, like a mini-pterygonal approach will be useful, and that has been done.
Okay, thank you. Dr. Benavides is asking, how feasible is it to perform a gross total resection of the lesion through the tones?
It's very possible. I've seen the images. It's very possible. I think it's a more direct way and more shorter. So you really find very easily to handle tools to this approach. It's different. It's different if you are used to use endonasal ports. So, for example, handling the scope will be tricky because in the nose you have the nostril that helps you to retain scope there, but in the orbit you don't have that. So it's sometimes tricky, but you get used to it, and it's very you have a wider angle of vision than in an open approach. I mean, most of these lesions, for example, trigeminal schwannoma, you'll have to do a very extensive open approach, and your angle of vision is not that good. So it's a morbid approach, and your angle of vision is not that good. And through the tones, it's a perfect procedure for that kind of lesions.
Okay, perfect. So we've got the next commentary. So thank you for your talk. Great technique. How many procedures have been you able to perform through this technique? Any postoperative complications related to the eye in your experience?
Yeah, as you see, there's no more than a bunch of cases in the world. So the person with most experience in that is the Laterally in South Korea. He has performed 40 cases. In my experience, I have performed 4 cases, and there has not been any bad adverse effects. The most frequent being diplopia, transient diplopia, and hyposthesia in the ship. No fistula, no severe spinal fluid leak.
Okay, and what about the encephalocele? Have you any case?
I don't, but it has been reported. Usually, you don't have to reconstruct the orbit, but if you have a very, very wide effect, you can use a medport. So some people are using medport, which is it's readily available, and it's very easy to use for reconstruction.
Okay, wonderful. Dr. Andraus is telling you, thank you, Dr. Saavedra, for your innovating and excellent lecture. And he has 2 questions. The first one is, how do you reduce the risk of elevating the intraocular pressure due to the constant displacement of the eye globe? And the second one is, under the scope of endoscopic skull-based surgery, is the treatment of vascular pathologies such as aneurysms. What is your opinion and or your experience regarding this particular technique?
Yeah, the first question. So what we do is releasing the brain retraction every 10 minutes. There's no paper saying we still don't know how long we can have retraction, or we still don't know. I mean, what would be the reason for, or if actually the intraocular pressure raise during the procedure? We don't know. But what we do is we think it could be elevating the intraocular pressure. So we just release the brain retraction every 10 minutes. And for the second question, it has been done. I haven't operated any aneurysm. But as I showed you the image, in this case, we thought the patient had an aneurysm, so we were ready to do it. We just had the clips and the forceps to do it, but I haven't done it yet.
Okay, perfect. Thank you. Patricia Suarez is asking, which is the indication of the use of isotonic solutions on continuous irrigation like Ringer lactate during the endoscopic technique?
Yeah, we do it regularly. We do it all the time. We usually use saline solution, and you have to do it all the time. Especially when you're drilling. And what we do now is we have some fissures on the eyelid to keep it closed during the procedure, so we don't have to use. We have to be irrigating the eye globe, but yeah, we do it regularly.
Okay, perfect. Hatim Belki is asking for postoperative eye edema, how to manage it, and other techniques to avoid huge eyelid edema. Thank you, doctor.
Yeah, that happens in the postoperative period. Patient has a huge eye edema. You have to prevent the patient to tell him before the surgery is going to happen, but it's uncomfortable for the patient, and it's not a really bad complication. So we don't have any special technique on that. Just waiting just around 5 days, 6 days, the edema starts to get better. And as you saw in the postoperative picture, the cosmetic results is very, very impressive. Patients are really happy with the cosmetic result.
Okay, perfect. So we've got some questions regarding the combined approach. So continuing with this topic line, when can be considered a transnasal endoscopic assistance plus tones?
Yeah, when tumor is going medially to the optic nerve and it gets into the sphenoid sinus, for example, then your angle of vision through tones will not be good. And also, when as I showed, the inferior and medial third of the orbit is better accessed, better addressed by a transorbital and the nasal approach. So it's really that third, the inferior medial third, that it's really better approach for the orbit. So you have a tumor that's compromising also this third, you will be wanting to have a combined approach.
Okay, perfect. And continuing with this topic line, what is your opinion on the exoscope visual aid? Does it have any role on this technique?
I haven't used it for this particular technique. I have used it for other kinds of surgeries, and I like it. I like it, especially when it's a 3D exoscope. But I haven't done that. I haven't used that for tones.
Okay, perfect. What is your opinion on what are the main contraindications to perform a tones?
Well, there are not like absolute contraindications. Just it's this tension of the lesions that will make you think about doing a tones or not. So there's has not been reported like absolute contraindication to do it.
Okay, perfect. The next one says, what is the advantage that a tones through a medial orbital wall would provide from an extended transnasal approach?
Well, there's very little experience in this approach, the medial orbital. I will tell you a personal experience. A friend, one of my friends, a fellow in Cornell, Dr. Mina Gerges, who wrote, published an amazing article on the anatomy of the infratemporal fossa through tones. And he had this nice idea of addressing lesions of the lateral recess of the sphenoid sinus through a pre-caruncular approach. So we just performed anatomic cadaveric dissections, and it turned out to be very useful. But part of that, there's not much more experience in that.
Perfect, thank you. Joaquin Seigel is asking, did you use the transconjunctival approach like precaruncular for lesions middle to the optic nerve?
No, I haven't, because as I was saying, that that can be done. That can be done. That it seems like doing it transnasally, it's more easy, and there's more experience doing it. So I use a transnasal approach.
Okay, perfect. I believe there are some other concerns about the possible complications. So the next question was written like this. What recommendations would you give for the management of postoperative enophthalmos?
Yeah, you can have that. You will need to use an implant. You'll need to use an implant. As I said, Medport is very useful. You can use titanium mesh, but that can happen.
Okay. And what recommendations would you give for the reconstruction of skull base during closure?
Well, as I said before, there's you don't have to do it. Usually, you have to use implants unless the defects it's extensive. So what I do is just use patch, a Dura patch, and I put it into the Dura, and then I use glue, regular glue, and then you just let the orbit to reposition its normal normal way, and that's pretty much. I do use lumbar drain for 1 day for 24 hours because you usually have like great large defects in the dura. So I prefer to use lumbar drain. I haven't had CSF leaks.
Okay, doctor. Well, wonderful. And thank you for your answers to these questions. So on behalf of CIEN, I'd like to thank you once again, Dr. Saavedra. We are really grateful and honored for your participation here in the 2021 IWBNC.
Thank you, Pablo.
Well, thank you once again. So for all the audience, keep in mind this lecture will be available on our website starting next week. In a few minutes, we will have Dr. Juha Hernesniemi doing his lecture about surgical strategies on previously cold aneurysms. To get the link for this upcoming conference, please follow the link pinned here in the chat or check the program schedule on our website, cienhus.com. Dr. Saavedra, thank you for your time.
Bye, Pablo.
Bye. Have a good day. Mm-hmm.